Hello, my name is Michelle Udikansky and I'm a freshman nursing student, and today I will be presenting a patient to you from Heartland Clinic. The patient is an 85-year-old retired Caucasian female. She's a widower with one daughter who is her primary caretaker. The patient has no allergies, is up to date on all her immunizations, and neither drinks nor smokes. The patient has undergone an appendectomy and a hysterectomy, but has otherwise never been hospitalized. The patient is currently on 21 different medications to treat her dementia, overall pain, constipation, muscle spasms, depression, diabetes, atrial fibrillation, and high blood pressure. When I entered the room, the patient was in good spirits and not in pain. The patient's chief complaint is of her right hip due to a fall she suffered, spraining her right hip. She was admitted to St. Joseph Mercy Hospital on March 25, 2013, where she was being treated after she suffered the fall. However, through rest and various pain medication therapies, she was then released to Heartland Clinic on April 2, 2013, where she would undergo physical therapy to help her regain her strength and mobility. The patient was bedbound and therefore had to be considered when conducting my assessments. The patient suffers from chronic illnesses including dementia, type 2 diabetes, and spondylosis. The patient suffers from dementia. She's alert and oriented times 1 to 2, meaning she knows who she is and where she is. During the patient interview, this was very apparent in that she could not tell me what day it was and that she was confused on the date she was admitted and the date she was being discharged. She also suffers from spondylosis, which is an osteoporosis specifically concerning the spine. It is a degenerative disc disease that shortens the vertebrae of the spine and causes pain. The patient's spondylosis is specifically on her L3 and L4 vertebrae. In order to treat this pain, she uses a variety of pain medications and a Bengay patch on her back. She reported to her back pain to be a 3, and it neither increased or decreased when she would stretch out on her bed. In the past years, she has also suffered a stroke. She suffers from slight expressive aphasia. During the patient interview, she would often become flustered, and her sentences would sometimes be out of order and incoherent. She would become noticeably flustered, displaying that she knew what she wanted to say, but was just struggling to say it. She didn't seem to show any physical signs of a stroke. While she spoke and performed facial expressions, they were symmetrical on both sides of her face, and neither side of the body seemed to be affected by the stroke. When I asked this patient how she felt about her health, she expressed that she feels as though she's in good health and is satisfied with it, although reports being very annoyed with how she stated how her mind seems to go. She reports that her weight has been constant, denies any fevers, chills, or night sweats. She denies excessive fatigue and reports that she's no longer very active and watches a lot of television. Upon my vitals assessment, I found that her heart rate was 86, her blood pressure was 137/60, and her respiration rate was 18. Because her chief complaint is the pain in her right hip, I performed the musculoskeletal examination. The patient denied any swelling, redness, warmth, or deformities, all of which correlated with my examination. She did, however, express some joint soreness in her lower back and right hip. However, she made note that this was not exactly painful, but only sore. The patient denied any limitations of range of motion. She denied any limitations performing daily activities. She also denied any weakness and assured me that the physical therapy was making her stronger. She reported a history of arthritis in her back, which correlates with her spondylosis. Because my patient was ordered to be bedbound, I was unable to assess her posture and gait or for scoliosis. I palpated her muscles for arrhythmia, warmth, and crepitus, none of which she presented with. The patient also did not express any pain during the examination, either verbally or through her facial expressions. I assessed all of her muscles for range of motion, all of which had full range of motion without any pain. It was then I concluded that her recommendation for her to be bedbound was precautionary rather than necessary. I tested her muscle for strength, and as reported in her review of systems, she was very strong, to which I graded all of her muscles on a 5. With her long history of dementia, I performed as much of the neurological assessment as I could, considering my patient was bedbound. The patient denied any numbness, tingling, or burning. The patient denied having any episodes of seizures or loss of consciousness. The patient was not concerned with her memory loss and claimed it was a normal part of aging. Although this is true, her memory loss was far more extensive than the average 85-year-old. The patient denied any insomnia. The patient denied unsteadiness or loss of balance or coordination. The patient denied any anxiety that interfered with daily activities. The patient denied difficulties with speech, and the patient denied any history of head injury. I began by assessing her cranial nerves. I could not assess her olfactory nerve in that I did not have something for her to smell. To assess her optic nerve, I assessed her visual fields by testing her peripheral vision, for which was normal. I was not equipped with an eye chart and was therefore not able to assess her visual acuity. To assess her ocular motor nerve, I assessed her cardinal fields, to which she was able to follow my finger with her eyes. I then assessed her pupil constriction, to which she constricted from a 4 to a 3, which is in the normal confines. Her trochlear nerve was assessed during the ocular motor tests. To assess her trigeminal nerve, I used a tissue to assess if she could recognize light touch on her face, which she could. I also had her clench her jaw to assess her master muscle strength. Her abducens nerve was also assessed during the ocular motor tests. To assess her facial nerves, I had her make various facial expressions such as smiling with her teeth, raising her eyebrows, pursing her lips, and puffing her cheeks, all of which she was able to do with ease. Because she was bedbound, I was unable to perform the Romberg test in order to assess her acoustic nerve. I was also unable to perform the Rinne and Weber tests because I was not assessed with a tuning fork. However, I was able to perform the whisper test, to which she reported the sounds being equal in both ears. To assess her glossolaryngeal nerve, I assessed her gag reflex and her uvula rising. Concerning her vagus nerve, her voice did not seem hoarse. To assess her spinal accessory, I had her sit up and she was able to raise her shoulders and move her head in all directions, also while pressing against my hand. To test her hypoglossal nerve, she was able to protrude her tongue, move it side to side, and say light, tight, dynamite. I then assessed her mental status. She was dressed in normal clothes and appeared to keep up with good hygiene. She was conscious through the entire interview and assessment periods. She was able to perform facial expressions I asked of her. She presented with normal speech patterns, occasionally presenting with expressive aphasia. When she would talk quickly, she would get flustered and her sentences would become disorganized and coherent. As reported in her chart, she is alert and oriented times 1 to 2. She was attentive through the examination. She was able to repeat the 3 words I said to her, but was only able to remember one of the words when I asked her later. I asked her to draw a clock, and she did. I asked her to spell the word world backwards, and she was able to. I then asked her to write a sentence on a piece of paper, and she was able to. I was only able to assess her lower motor functions and fine extremity motor functions because she was bedbound. She was able to touch her fingers to her nose, and her finger to my finger, and then to her nose. She was also capable of moving her heel up her shin. I used a pencil to test for light touch and painful sensation, the eraser being the light touch and the lead being painful. She was accurately able to distinguish between the two. I was not equipped with a tuning fork and could therefore not attest for vibratory sensation. She tested negative for stereognosis, graphesthesia, and proprioception. She also tested negative for the Babinski effect and ankle clonus. Because the patient has suffered a stroke in the past year, I would also want to perform a cardiac assessment on this patient. Most of the medications she's taking are in response to atrial fibrillation, specifically Coumadin. According to the Cleveland Clinic, Coumadin is a blood thinner used to prevent blood clots, which could eventually lead to a stroke. Because the patient has already had a stroke, she is at a higher risk for having another. One of the specific treatments of Coumadin is the treatment of atrial fibrillation. Because she is on this medication, I would expect to hear that during my assessment. I would also want to perform an abdominal and nutritional assessment on this patient. Because the patient is a type 2 diabetic, there are certain dietary precautions she has to take. Also, because she is taking this medication for constipation, I would assess as to how that affected her diabetes. I would expect to hear slow bowel movements as I auscultated, which would correlate with her constipation. According to the study by Dr. Stuart Haynes, constipation is common among patients with type 2 diabetes and should be monitored with various medications, diet, and checkups. and that is my patient.